Welcome, everyone. Everybody is coming in and all are allowed. Excellent, excellent. So happy that everybody is here today. We'd like to start off by having everybody open up their chat box. And if you can open up your chat box and let us know who you are by introducing yourself. So you'll see there's a box and you can go over and let us know what your name is and what organization or OHT or other organization that you're from. And Jodine starting us off. Welcome, Jodine. Please make sure that you chat when you do this, that you send it to everyone. Hi, Deb, Paula, Carolyn. Okay, and now they're coming fast. Hello, Laura. Wow, really fast. Jackie, Ted, people from York, people from Health Partners, Toronto Health Partners, RISE, Ottawa, Algoma region, welcome. Alan Katz, welcome. Everybody, let us know who's here. People can have a look through to see. We had over 300 people register for today's event, and hopefully many of them will show. It looks to me like we definitely have quite a few people who are in. Angie from Care First, Sanjeet from RGP Toronto, Wendy from RGP Toronto, Laura from Kenora. Welcome, Laura. Great to see you online today. We're all set to have a great event and a good conversation. That's what we're really here for today, is to have a good conversation. Mary from Wood Green, Clovis from 360 Kids, New York. People from many different backgrounds and representing many different groups. Dominique from the ministry. Welcome, Dominique. Really pleased to have so many people joining us today. Tori from downtown East Toronto. Amber from Ontario Health West. Welcome, everyone. Okay, we are going to go ahead. We've got a great event lined up today, and I think some really good discussion that we're going to see. We have with us our team, but we're going to start off just by letting us know if this is the first time you have met our team at HSPN, or if you have joined us for a webinar previously. We're going to launch a poll so that we can have a sense of how many people are new to us and possibly some of our evaluation work. So here we go. Please respond. Let us know. You can go over and you can click in and vote. Have you joined us for an HSPN webinar before? Welcome for those that are just joining us. Luann from Western York, Rebecca from South Simcoe, Sherry from Chatham, Kent. Welcome. Please let us know where you're from. Use the chat box over on the side, and then also you can enter in whether you've joined us before. I think we can close the poll now. Oh, there we go. We just want to take a moment and acknowledge the land we're on. Nusrat, you can lead us.
Okay. One moment, sorry. There we go. So we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron, Wendat, the Seneca, and most recently, the Mississauga of the Credit River. Today, this meeting place is still the home to many Indigenous people across Turtle Island, and we are grateful to have the opportunity to work on this land. We acknowledge that Canada is home to many diverse First Nations, Inuit, and Métis peoples, and that each of you are joining us from one of those many traditional treaty territories.
Thank you. We have over 200 people have joined us so far already. Just want to take a moment to introduce our team that is sitting behind all of the work that you're going to see today. First off, myself, Dr. Walter Wochis. I am co-lead for the Central Evaluation of the Ontario Health Teams. We have with us Dr. Ruth Hall. Ruth is there in her library, who's also a co-lead. Also with us today, Dr. Gaia Mboldania, who will be speaking with us about some of the findings from our interviews. I know that Shannon Sibold is online. Dr. Sibold, I saw her sign in, so she's out there and may comment along the way. Amanda, Jennifer, Kevin, and Nusrat are all on our team. and provide great support and undertake a lot of the work that you're going to see today. I'm going to give you a quick little overview of today's event. First off, I'm going to host a little bit, and then we are going to have 4 people speaking today. First, Dr. Ruth Hall will lead us through our document analysis and what we learned about the teams that have applied, and then get into survey results. Hundreds of people answered our surveys earlier this year, and finally we are able to bring you some of the high-level results. Most of the teams did see their own feedback from the ones that participated earlier, and we're going to bring that to life a little more. Dr. Mbulania is going to talk to us about the interviews that were undertaken by our qualitative team. And then we have the great fortune today that Alison Costello and Lily Whittam from the ministry are going to, we've been engaging and talking with them about what we've been finding, and they're going to tell you a little bit about how it's informing their work and the supports to Ontario health teams. Overall, we're going to review this central evaluation and our overall plan, and then get right into the formative evaluation with the document analysis, leadership survey, the interviews, and then we're going to have discussion and questions along the way, but also a devoted time at the end for you to ask your questions and actually for you to share with each other along the way. Perfect. Thanks. So this is just a quick overview. Up on the left, you see that those are the 3 components of the evaluation that we're bringing to you today: the document, the survey, and our interviews. This is all part of what we called phase 1, which was in that we undertook the data collection last year, and we were undertaking now, moving ahead to this year. So you can see phase 2 now is where we're headed to now, which is developmental evaluation, working with the candidate OHTs. And we'll be, over the next 18 months, working at both a macro level with all of the teams, and also at a more micro level with a subset where we're trying to understand and do more interviews and participate more fully in the implementation of your work. And with that, I will leave it to one more poll to find out where people are coming from. Okay. So everybody should be able to see an answer now. Did you join in the first round? Are you in the second round of OHT applicants, which interviews started today and the virtual site visits started today? Or do you have another role in the OHTs? And let's see where we got to. Okay. So thanks everybody, and now we're going to head off into the heart of our material with our document analysis. Ruth, I'll leave it off to you.
Thank you, Walter, and good afternoon, everybody, and thank you for attending. So as Walter mentioned, the formative evaluation used 3 data sources, and first one being your full applications that we combed through and tried to pull out key aspects. We wanted to know who's involved, and you know, first and foremost at the center of the OHTs are the patients. And well, it was great to see that we had really very high group of the OHTs that were evaluated to be at high or medium levels of engagement. And high engagement meant that you had patients and families and caregivers as co-leads and or part of the governance tables, and they may or may not have been a signatory on the application. Of those 18 that were deemed to be high for patient involvement, 8 of them actually had a patient, family, or caregiver as a signatory. In terms of organizations, the key players or organizations that should be in these OHTs are the hospitals, the primary care, community services and support services, as well as home care. And we know that primary care is a key player in this. And so we're focused a little bit here in highlighting this particular group, is that there was relatively low physician participation in the full applications, and that we found that the FO was the dominant primary care model. And on average, there was about 81 primary care physicians across the OHTs, and this varied from 20 to 186. The priority populations identified by the first round of OHT applicants, most prominent was the frail, complex older adults, mental health and addictions, and then followed by palliative as the top three. And then our chronic diseases after that. In terms of performance metrics, important to us is the central evaluation for this initiative. The most common was avoidable emergency department visits, patient and provider reported experience, and 30-day inpatient readmissions, sorry. The document review, we created a report and soft launched that in May. So just in case many of you weren't aware, it is on our website, and there's a full report, a graphic report of it, and then a little infographic. We just shared a few key components of the analysis that we did to inform our interviews, as well as to help in any future analysis to provide context for us. Next up is the leadership survey, and that was launched in the winter, and our objective was to capture the early phase of the team building and new and more integrated ways of organizing and delivering care to the initial focus populations through this web-based survey. And again, we've launched the full report. Many of you have seen it. We sent it out to you over the summer, but it's now up on the website for those that need to and want to look at it in further detail. The survey consisted of 42 items that were selected from the Context and Capabilities for Integrated Care Toolkit that captured 10 domains, and they do align with the ministry's building blocks that were in your guidance document. And you can see in many of the questions seem to cluster around the digital health, leadership, in-scope services, patient care, and experience. We identified respondents through looking at Section 7 of the full application, and we requested the contact information for one representative who was most involved in the application process from each of the signatory organizations. And that gave us a contact list of 765 individuals, and over the winter that was completed, we had an overall 63% response rate, which is excellent for surveys, and on average the OHT response rate was 77%, ranging from 27 to 100%. So on to our results. The 10 domains that I mentioned, there's leadership, shared vision, team climate, clinical functional integration, readiness for change, commitment to improvement, roles and responsibilities, administration management, financial and other capital resources, and non-financial resources. So our top domains was the commitment to improvement, averaging 4.2 out of 5, followed by team climate, administration and management, and change readiness. In commitment to improvement was really nice to see. It was the highest rated domain, and about 2/3 of the OHTs had 80% or more of their respondents that selected the top 2 boxes, so that we're feeling strongly or moderately agreed that they had a common vision of how to improve the integration of care, and they've agreed to share responsibility for achieving improved patient outcomes, and have used data to identify the improvements for the target population. So that was quite that was really amazing, we thought, at this early stage in the formation. Administration management was also rated highly, and nice to see that half of the OHTs had, again, at least 80% selecting that they felt they were excellent or very good at communicating among the members and organizing their activities, including meetings and projects to move this work along. I think it's nice to add some color to and actual quotes that reflect these high ratings for these domains, and things like, I think that the collaboration with people that we have not normally collaborated with has been wonderful. Just the commitment and willingness to come together and do the work has been amazing, just amazing. And in speaking about administration and management, one of the interviewees commented that he's made sure the trains run on time and made it really easy for us to step up. And he's really good at moving information among partners and convening meetings. The lowest domains, not surprising, was the financial and capital resources. So that's all about money and tools and technology. Secondly was clinical functional integration. And this is about sharing tools and information for across members. And then non-financial resources was also near the bottom as well. And in terms of clinical functional integration, this is really a critical part of how we're going to move forward with OHTs. And there was not a single OHT that had over 80% of the respondents saying they strongly or moderately agreed that they can share tools for clinical coordination and can share clinical information across their providers. And in terms of the non-financial resources, again, all these three low rated domains, there was not a single OHT where 80% or more of their respondents selected that they had all of what it needs or most of what it needs in terms of skill and expertise to do this work, having data and information, having the ability to identify target population criteria and deliver the interventions, as well as connections to political decision makers, government agencies, and other groups to, ensure the legitimacy, support the legitimacy of the partnership. I think this quote reflects this the low ratings, and that one of the OHT leaders felt, I think, both from a commitment to quality improvement and an active learning system, you need data that's operationally available to you, so you need to be able to manipulate it and you need it quickly. I don't know if you recall, but effective leadership was one of the key domains that's important for integrated care, and it did not rate in the top quintile. It rated 6 out of the 10, but when we looked at specific questions and knowing that trust is an essential underpinning element of successful partnering to deliver better or more integrated care, it was really encouraging to see that the mean score was 4, and 2/3 of the respondents felt that their OHT leadership was very good or excellent at fostering trust, and as well creating an environment where differences could be voiced. So that was encouraging, despite the overall domain not rating is so highly. So in summary, for the survey, we learned that all OHTs have room to improve. There is no OHT that consistently ranked above the 80th percentile across all domains. And province-wide supports are needed to enable successful integration. All OHTs are lacking the resources, both financial and non-financial, and clinical functional integration, like patient registries, clinical information, and managing the resources. All OHTs will need support to ensure their members understand the clinical tools for coordinating care and be able to share that clinical information. And there are going to be some targeted supports for for some teams. Most, but not all, share a common vision of how to improve the integration of care and agree to share the responsibility for improving the patient outcomes. And again, most OHTs rate their leadership ability to foster trust and respect and creating a safe environment. But half of the respondents, the OHTs actually had over 80% or more of the respondents rating their leadership highly. Sorry, not half, a third. Half of the OHTs did rate their administration activities being really effective among, half of the OHTs had 80% of more of their respondents saying their administration management was very high. And they did feel that a dedicated project lead was an indispensable resource. So now we have a third poll here, and I'll hand it over to Walter to walk you through that.
Great, thanks. And everyone, I'm starting to see a chat on the side, a few lines of conversation, one around information sharing. Such a challenge, it seems, and thinking about, does it really make sense for individual OHTs to be sorting this out? Or maybe there's some real value in creating some provincial and taking advantage of the provincial resources. I encourage you to keep that discussion going. There's a lot of knowledge and deep depth in the field among our audience today. There's also a conversation running around creating space and how do you create trust. And I know I was on a conversation with a local site the other day where knowing that the staff felt that they could speak up and talk about the problems they were having is so important in being able to really be a sign of trust. So just some highlights of examples there at the end. We are interested in, as we've gone through a number of these headings, what are some of your OHT areas that you think you're going to be working on, or if you are not personally part of an OHT, what do you think OHTs should be working on in the first year of implementation? We think there's more than one thing. Maybe there's only one thing that you're going to focus on in the first year. But we've listed off here a couple of the things that we've been talking about so far today that we've seen as being important in the OHTs, from patient to community engagement, primary care, developing a common vision, communicating the vision, empowering OHT members. We're going to give you a little bit of time so you can check a few here. Right down to the clinical information sharing, to patient registries to be able to identify people. And then finally, some of that administration. What are the areas of focus that'll be most important for you? You can choose a few. We haven't set how many. We'll leave it up to you. We're very interested in seeing what comes. I'm gonna leave it up for about another 10 more seconds, and then we'll have a look at the results here. So there we go. Patient and family engagement being right up there in primary care engagement, and developing a common vision. So all of these in various aspects, many of them are coming up with very similar ratings, which is quite interesting. That there are many things people are going to need to be working on at the same time. So that's going to be a challenge to organizations, but it's also an opportunity. And I think it's going to be an opportunity also for some shared leadership and distributed leadership, because one person or a few people aren't going to be able to do all these things. Going to need to be able to do many of the same time. I am so pleased now that we will be understanding a little bit more from the interview aspect of our deep conversations within a few of the teams. And I'm going to turn it over to Gaia to walk through the next few, really bringing some of the survey results to life at the ground level. What does it really mean? Thanks. Go ahead, Gaia. Oh, Gaia needs help.
Thank you, Walter. Okay, hopefully everyone can hear me now. It's really nice to have everyone join us and to be able to share these qualitative results, even if it is going to be rather high level at this point in time. So if we can just, I guess we could start here. So what we were trying to do with the qualitative interviews really was to figure out what the process of developing an OHT looked like for participants at this early stage. So, how did participants go about developing their OHTs? What was important to them? What went well? What helped? What challenges did they face? How did they perhaps go about dealing with and transcending these challenges? What yet remains to be done? So it was very much basically trying to understand what works for whom and in what circumstances. So we used a stratified random sampling approach to select 12 OHT applicants across geography. So from urban, suburban, rural, as well as hospital-led, non-hospital-led. So we ended up with a range of differently sized OHTs across this geographical spectrum. We had at least one with 43 partners, another with 7 partners, and we included approximately 10 individuals from each OHT, right? And we tried to include as many as possible across sectors. We had some sort of representation cross-sectorally. And these were individuals that the OHTs themselves helped to identify. Next slide, please, Ruth. So our participants were administrators, they were patients, family members, as well as clinicians. Many of these clinicians happen to be primary care physicians. So we conducted 110 interviews between January and March this year. We're still working on our last 12th OHT. We've got 12 additional interviews that have just been completed. The interviews were transcribed, they were thematically coded, and they were then analyzed. We're actually still in the process of analyzing them, and they will eventually result in reports, and manuscripts have already resulted in a few reports, I suppose. Okay, so I guess what I should stress is what I'm presenting right now is very much a snapshot in time, as we sort of iteratively immerse ourselves in this data, what we get out of it will evolve. Okay, so we identified 5 preliminary components of OHT development that resonated across participants. The first being building on existing relationships and scaling up programs, interorganizational collaboration, primary care engagement, patient and family engagement, and the need for policy, resources, direction, basically guidance in some form, right? So these were 5 components that was cited as strengths when they were present, challenges when they were absent, or the aim of strategic interventions and future plans. Next slide, please. Okay. So building up on existing relationships and scaling up programs. So unsurprisingly, as much as they could, participants really tried to leverage on what already existed. So this could be building on established community connections, digital health innovations that were already in place, perhaps existing patient and family advisory councils, the ways in which, methodological ways of sort of identifying priority populations, anything really. So this is a participant really talking about the efficiency that was born out of existing familiarity, right, with fellow team members. So we already had a model in place here with many collaborators around the table. And so working through the trials and tribulations of getting people to take off their own organizational hat and look through a different lens for the common good of an integrated service delivery model is something that was already worked through over several years. So therefore it doesn't become the linchpin of this function, if you will, for this particular purpose, because it's already in our rearview mirror. Next slide, please. So, this is a specific aspect of interorganizational collaboration that this particular quote is talking about, right? So governance. So essentially how to actually represent, how to structure collaboration. So many hospitals actually really did understand that in order for this model to work, there needed to be investment in some form, in a substantial investment, ideally in the community sector. So this did represent a sea change of sorts for some. So, you know, lots of time was spent on governance, on figuring out how to do this representation. And this is actually a physician talking rather reflexively about the power and the influence that primary care has. So we have an awful lot of power, an awful lot of influence. In this case, it was, you know, you need primary care, you need doctors to be involved with this, because if the doctors aren't involved, you're sunk, right? So in this case, primary care, in other cases, patients and family members or home and community care were given a larger proportion of votes, because that's kind of what it took to get them to the table. Okay, next slide. Okay. So primary care, by and large, very much thought that the OHT model was a good idea, right? So, I mean, who wouldn't want to have a better coordinated system after all? So the problem was very much in the how. So how to actually operationalize this thing. So for many physicians, if they actually attended OHT meetings, they were very much losing out on being able to care for a patient. And in addition, they might be losing out on financial resources as well, right? Because the colleagues are actually being paid to be present at these tables, whilst they are not. So you hear this concern here. I'm very much trying to get off the train, says this particular physician, because it seems like there's a lot of demands on my time now. What I'm trying to do is not maybe be on as many action tables and not maybe go to every committee meeting that I could attend and not go to all these sessions that the ministry puts together to do what? To sit around and schmooze with other people and get their fantastic ideas. Well, that's just a burden. You're not supporting me. You're actually taking me out of my normal comfort zone of seeing my patients and taking care of people. And it was a bit of a problem that this particular physician from this particular OHT was thinking like this, because he was very much seen as the linchpin, right, that sort of pulled everyone together for this OHT. Next slide. Okay, patient and family engagement. So patients and family members, caregivers, they in a way, they were one of the most important things or factors that helped generate the sense of unity across OHTs. So if there was a lack of consensus, simply asking the question, what's in parents' best interests, sometimes helped. So you see a physician talking about this here. Having patients and families in every conversation also helps us stay true to the cause. And I think it does help people just check their behaviors a little bit to say, is this coming from a place of altruism and what's best for people? Or is this coming from a place of protectionism? Okay, so to end with, you know, just a sense of what people were thinking on policy, resources, and direction. So by and large, OHTs were craving direction, right? They wanted direction from the ministry specifically as it related to home and community care. So there was a lack of clarity about the future state of home and community care. There was an expectation that it would sort of transition to the OHT domain given the dissolution of LINS, but there wasn't a very good sense of how and when this would happen. And this sort of affected how people you know, thinking about the care coordinator role, then digital health solutions, again, they're dealing with their usual problems of what systems to use. Should we perhaps defer making decisions on, you know, settling on a particular system or software in case things change down the line? And we're told that we sort of all need to migrate again to a new system so that OHTs can sort of talk to each other. There was uncertainty about PIPA legislation at this point in time about how this would be changing in the months ahead. There were also other issues about, you know, attributable populations. So, you know, sometimes there were discrepancies between the ministries and the OHT's own understanding of attributable population. There was little sense of, you know, the funding aspects of this, or how the funding model would work. And there was also some confusion about when they were even supposed to be to start implementation. So you kind of hear that here. We're crying for leadership and direction, and we would love a singular direction and a requirement relative to where time, money, resources, and energy went in. Okay, next slide. So to tie this all together, it is rather undeniable that for many, the OHT model was very much seen, right? It was seen as something that was needed. And some of the things that helped with the process of OHT development included building on existing relationships, sort of centering patient and caregiver needs. But at the same time, a lack of funding, a sense that there was a lack of direction were key concerns. And these in turn informed other concerns, such as the difficulty of developing digital health solutions and designing care coordination functions. Reluctant primary care engagement was another issue, especially given structural changes that were sort of required to be in place to sort of begin with, that would enable physicians to feel that participating in OHTs would not be at the expense of their patients and pay. So while participants were concerned that a lack of guidance, resources, and policy facilitators might slow down OHTs, many vowed to push forward regardless. So essentially, it seemed that at this early stage of development, 100 flowers was sort of blooming, right? So lots of great ideas and different ways of doing this, but behind it all, there was this yearning for sort of guidance, standardization, and need to sort of put in structures of some sort. And without this, there was a sort of, I guess, a certain precariousness that undergirded the hopefulness. So with that, I'll hand over to Walter.
Thank you so much, Gaia. There is so much depth here, and we have only actually really started to unpack a lot of the information that we gleaned from doing these, well over 100 interviews amongst the, and we have a bit of a mantra as since we've started our evaluation work, and that is that everyone is involved. So the question that we are hoping right now is to hear from you, given these findings, what are your priority areas? So not just the summary of patients or provider engagement or primary care engagement, but when you think about what it is that you need to work on a little bit, and we're going to use the chat, and I will bring voice to a number of these. So OHTs, endeavoring to address wage disparities. And I know we've actually over the summer done a couple small side focus groups, and it's come up with a number of particularly PSWs, but other types of workers as well, where they do see disparities in wages across the system, and coming together, that might be an issue. But what are the kinds of things that you're thinking about now as you reflect upon your OHT and the ways that you're coming together? We're very interested, and others who are on this webinar, over 218 people that we're at now, to think about, what is it? Let's hear from you. Ray had a comment, what should be common versus local decisions? And we should think about that. What should be standardized? And that can then be, maybe more efficient and lower cost to provide resources and access to many people, as opposed to having to invent your own space. So use the text, don't be shy. Oh, great, people are writing a little longer, so so maybe you don't have to make it too long. We need to have the courage as leaders not to behave to be politically correct. Thinking about, what differences might be in the GTA versus others. Thinking about disparities and how organizations are funded. Please make sure that when you're sending your notes, that you send them to everyone and not just to me. Working on designing a community-based integrated delivery model. Reducing duplication, using regional resources more effectively. That sounds like a really, really great idea. Thinking about that backbone support. We need to have a backbone support. And there's probably great value in that backbone support across the province to allow both, we'll just give a little bit of a forbearance on some of our summary conclusions, where there are common needs, and then to have more tailored supports where there are more unique needs. So I think that's the part of the backbone, is to have that adaptability and flexibility to provide common supports to everyone. You know, we'd see ourselves as being that kind of common support through the evaluation team. Needing to look at regulations, thinking about French language services, and I think that speaks into diversity again, right? Enabling that the diversity, looking at what patients and caregivers want. We highlight, and it's a little intentional, that when we go through our results, that we put the patients at the top of our list of results, because this really is about getting better care to patients, and we won't know if we're doing well if we haven't involved patients and caregivers in doing this work. This is not about giving providers solely better work life, but it is about giving providers better work life for certain, but also with the mind to improving the experience for patients. That is at the core. Current areas of even getting flu shots to as many people as possible. That's really essential right now. Thinking about diversity, how it impacts access to healthcare. We think equity is going to be front and center in the work that we're doing on evaluation here. And as we think, and you're going to start to hear about some of our thinking around population health management and helping to support you doing population health management, as well as other groups in supports that we'll talk about a bit later, helping with population health management. And I was reading a blog on Health Affairs the other day about thinking about segmentation, which also gets to making sure we have good services for diverse populations, and other things we might, you know, in the current public health situation, also be thinking about our risk factors around COVID spread. How does that balance against getting people influenza vaccinations, which are not done virtually? So we need to make sure that we're paying attention on all fronts, and it will be a challenging time, but also a time of great opportunity to be able to come out the other side of this. In fact, all the way through it, we're not coming out the other side, all the way through it with a consciousness of improving the patient experiences. So we're seeing a lot of really interesting, so keep the chat going. There are concerns that each OHT becomes silos, need commonalities. Yeah, that technology comes up again, of where they can be, you know, common supports. And yes, patients are number one, but focused on increasing staff happiness is a beneficial way of promoting work ethic. And, you know, if the staff are not happy, they're not going to be paying good attention to patient care either, right? Patients are going to know whether the staff are engaged and involved and focused. So it is through supporting staff that we will be able to support patients. Support for primary care engagement and backbone being so important. So you're hearing a lot of this from many different avenues. And you're going to hear a little bit about some of those, what we do have in terms of some supports that are common, and some of the more tailored ones too. So I think with that, it's good discussion. I'm just going to scroll through a little bit more. Compassionate and authentic leaders with great sense of humility are needed. I teach finance. I teach a couple courses at the university, and I had perhaps the kindest compliment sent to me by a student about 10 days along with my co-instructor for the course. And that they said that when we approached our class, the thing that the student felt compelled to write after 2 months, they'd been thinking about it. And I said, you know, I meant to write this before, but I just feel so compelled to write this, is that as we came into class, while we knew a lot about the topic, he said that he really felt that we came in not feeling we knew everything that the students needed to learn, and that we learned with them in every occasion. And I think that's a great compliment to me. It's also why I teach. I have great fun in my class because I do get to learn. But I think it's also, reflects that comment from the about leadership from Ivan. Thank you, Ivan, for that. Thinking about, you know, coordinator, I'm looking at these comments. There are many of them. I encourage people to scroll through a little. Coordinator support for this work, digital health, equitable access, equity, and looking at some of the regulations that get in the way. And the ministry, I think, will also, they've been looking at this, and they've been thinking about ways that they can support the teams and also ways that they can get out of the way. So with other sectors to the table as well, that is important. If we start to think about population health, we're going to need to be thinking about social determinants of health, which is well beyond ensuring just that medical care is provided. Ensuring that privatization does not progress at the detriment of quality. I think quality and patient experience need to be at the forefront. Honestly, I'm a little ambivalent as to private versus public delivery. I do believe in the public financing and payment for our healthcare system, and we don't want to be privatizing any of the insurance and payment mechanisms. We already have a fair bit of private payment, which is already obstructing some people from accessing the healthcare they need. So we need to make sure that we preserve the public nature of our system. And when we think about some things like new technologies, ensuring that there's equity in access, and it's not that seniors can't use it, it's just maybe they don't have it. We've run experiments in the past where we have found seniors are very able to use it. Many people, they just don't have it. More upstream thinking with a stronger focus on social determinants of health. And I noticed Andrew Pinto was one of our participants today. I didn't get to call out on you, Andrew, but I know Andrew has a lot to say about this and is also participating in some of the supports to OHTs. So I think that's also something to definitely keep our eyes on. So I think, Neil, maybe we'll move on a little bit. We have a few more things, and we want to hear from our ministry colleagues as well. So I'll turn it back to you, Ruth, just to make a few concluding remarks about our impressions overall.
Can you hear me? Okay. Thanks, Walter. So we've come to the end of the formative evaluation, and just to try and summarize it in a couple of slides. OHTs are on board and to see this transitional change through. So that's really, really encouraging. But all OHTs are going to need the resources and support to establish a robust health data infrastructure to support care coordination, sharing clinical information, patient registries, quality improvement, and population health management, as well as enabling them to evaluate the implementation of the comprehensive integrated care that's they're planning for and soon to implement. Targeted supports will be needed for some OHTs in the areas of leadership, administration and management, and developing a common vision for integrated care. We do recognize and learned that primary care engagement is limited at this point in time when we captured this in the survey and in the interviews, yet it's critical to the OHT model. When you're having primary care physician participation on average less than 100, we need to do better. Patient and caregiver engagement, on the other hand, is better than the primary care. And it is critical for team dynamics and for designing integrated care pathways. So I'm going to hand it over to the ministry, Allison or Lily, to walk you through their response to the findings from the formative evaluation of this first cohort of OHTs.
Thank you so much, Ruth. I hope everyone can hear me okay. But before I jump into our slides, I just wanted to, say a massive thank you to the team here at HSPN for going through the work of beginning phase 1 of the evaluation. This is incredibly helpful and rich data, and we're so grateful for all of you who have contributed to this. It's not lost on us that being able to collect this kind of information is a big effort on everyone's part, and we're so grateful to have it. And I want to acknowledge that we are using all of this information to inform how we grow and evolve our OHT Central Program of Supports. So we know there's more to do. And we're delighted to begin this conversation in terms of developing future supports and filling some of the gaps. I wanted to take the opportunity to highlight some of the existing supports that are available to you. What you have here on the slide is by no means exhaustive, but we wanted to focus on some of the key things that are available right now based on some of the areas that you've identified as challenges at this point in time. So specifically, we've heard that you need support in understanding your attributed population and having access to tools that can help you move towards a population health management approach. Some existing and planned supports are available. Some existing supports are available on the RISE website. Some really fantastic evidence briefs that are there that will help in terms of moving you and your team towards that population health management approach. We've worked to provide data packages in terms of some of the digital health connections. There is a digital health playbook available, and Walter and Ruth and team are working on a pilot right now around population health segmentation that we think will be really valuable to move you forward in this area. For those looking for supports around leadership and collaborative decision making, we know this is a critical focus for most of you right now in completing your collaborative decision making arrangement attestation for the ministry, and is just an essential foundational building block for the OHTs. So we hope that the guidance that was released in late July has been helpful, and that you have taken advantage of the advance workshop that is currently underway and being led by Dr. Ross Baker for the approved OHTs. We also know that patient and family and caregiver engagement has been a challenge, especially during the height of the pandemic. This is another area where RISE has materials available to support, and we are also really excited to begin working closely with Betty Lou Christie, our new Minister's Patient and Family Advisory Council Chair. Walter reflected that there's a lot of depth in the information that has been provided, not just in the evaluation, but also in the chat. I haven't been able to keep up on all of it, and we're so excited to look through. We know that you need more guidance. We hear the asks for standards and a space to share information. One thing I wanted to mention is that the RISE team has been working to develop a platform, Quorum, which many of you are familiar with, for OHTs to share and to start building communities of practice. I'll go into the next slide, which speaks to one common theme, and Ruth emphasized this in doing her summary key messages, is that primary care engagement is a challenge. And we know that it is essential to successful OHT implementation, and it goes beyond engagement, but involvement of primary care in the planning, the operations, and the leadership of the OHT. We heard you loud and clear that this is an area where help is needed, especially given the diversity of primary care practices and the challenging times with COVID-19. We do have work underway in this area that we hope will provide some tools and guidance to help with this. Specific things that we're working on are a collaborative bilateral table with the OMA on this specific topic, physician leadership and engagement in OHTs. We have existing Ministry of Health and Primary Care advisory tables that we're tapping into for advice. Our partners in the central program of support include the Inspire team, Dr. Mike Green and Dr. Rick Glazier, who have done a ton of very helpful and supportive research and making data available around primary care involvement in OHTs. And we're also working with the Center for Effective Practice. The RISE team has recently brought all of us together to start identifying gaps and opportunities, and we're taking all of this information in to develop a strategy we hope will help you in engaging and involving primary care. And that's not to say, wait, go ahead with your plans. I know many of you are working very, very hard in this effort. And we don't want to hold anything up, but just wanted to acknowledge that we've heard the need and the ask. So that's it for our ministry slides. I saw Allison maybe take her video off, but I'm not sure if you wanted to add anything, Allison.
I took it off because you had so ably addressed everything that we wanted to say. We're both here to answer any questions and support the discussion at the end of the meeting, but thanks so much for the walkthrough, Lily.
Great. Thanks very much, Lily and Allison. And I'm so happy to hear you both. There's a question, Lily. Are the Ministry of Health and OMA advisory tables open to new members if primary care physicians from our OHTs want to get more connected? So I think this is about how do we enable more physicians to have a link into that.
Yeah, I think that's fantastic advice, and we would love to hear from folks that have good ideas about how we can get more of our primary care physicians involved and hearing their voice and hearing their perspective. If there's interest in joining existing committees, it's really helpful to hear that, and any other thoughts and ideas about how we can support interested leaders in this space to share their ideas and suggestions.
And Rachel Labonte has a comment that we heard definitely in our interviews, and I think is cognizant both to the Ministry of Health and the OMA, is around a number of the existing primary care partnerships and tables are great. And a lot of the people who are incredibly engaged are physicians and frontline providers, but often the same frontline providers. And for this overall program to be a success, there will have to be engagement. And I think, is figuring out what's the right titration of engagement a little bit amongst different physicians in order so that the other 80% who aren't at the tables do see this as valuable and worthwhile. Has anybody have thoughts about good ideas or thoughts about physicians who have come along later in the game and why? And I know I had an executive, saw a note earlier this week from an executive director for a FO, actually might have been a FIT, who was asking, they are doing quality improvement. What's the benefit of this?
I would have a little bit of a comment on that, as I think we've been thinking a lot through that as well, and that I would say, although certainly the findings that you guys have shared today represent that there's still a lot of work to be done on engagement of primary care locally at these tables, I still think across the province it's been pretty remarkable how much activity there has been and how much willingness there is to lend time to something that has a lot of unknowns attached to it. And we appreciate that. And I do think, and we've had conversations with some of our sector partners. So we do have a formal table with the OMA, but we chat regularly with AFTO, OCFP, the section, and NPAO on other, keeping a kind of finger on the pulse of what's happening. And in early discussions with those groups, there's been interest in not only supporting the OHT activity, understanding how to support involvement locally, but really noting that we have to kind of look to generate that next cohort or area of those local leaders that we have consistently gone to, who have been the ones that we consistently go to, so that it is a broader network and there's more. I think there's been a comment earlier on in the chat about this being training from very early on about how to engage in system level enterprises. So I think that's been something that we've been hearing about, and I do think that there'll be a lot of opportunity to participate locally, or more opportunities that will make themselves available as we figure out more of the activities that we hope to undertake to support involvement for primary care.
Yeah, thanks very much, Lily and Allison. A couple other comments coming up the side. Eric Landreau, our OHT planning on using implementation funding to provide stipends to primary care leads, in particularly some areas of healthy aging, equity, et cetera, to foster that leadership and participation. I mean, this is change management, and anything needs local champions for sure, and that's quite useful. A suggestion of the OMA perhaps advocating for more standardization on how physicians are compensated across. Jodim noting that that's a lot of acronyms, 5 different physician organizations in Ontario launched the primary care virtual community over a year ago and engages broad ranges of primary care. That's one opportunity as well. That is pretty amazing. There are a lot of people, a lot of physicians participate in that online community, virtual community. And an opportunity, Dave Pearson says, for primary care to be viewed as co-designers of the change in the local community. And that's one of the things that I've felt too. There are different forms of reward and remuneration, and one of them is being involved and having a voice in decision making, and not just in consultation, but also in decision making. Participation compensation is an interesting conversation, as patient and family reps are not always compensated, from Tara McKendrick. I think thinking about participation and compensation in equitable ways, I think across the board is an important consideration. People who are coming to the table to participate in OHTs need to feel, I think, respected, and they need to feel that they are equally important. And I think that's something that the funds being used by the ministry or being provided by the ministry to people who sign up with good agreements are also able to be used for. As useful. Little angel in my ear just reminded me that the OMA is actually having a primary care engagement tomorrow on Wednesday, and this will be a considerable focus for that discussion. So thanks for reminding me about that. I have a question that I see earlier from Paula Blackstein-Hirsch about whether implementation funding can be used related to their backbone support. Use of implementation funding for backbone support. Is that, that's the specific question is, are OHTs able to use the Ministry of Health implementation funding to support backbone supports? Lily, you're on mute. You might have to do something about that.
Alice and I are having the exact same problem.
We're very concerned about background noise in our houses, even though you trust us to remain quiet during our listening periods. So I saw some of the questions that came through, and we, Walter, if it makes sense, like we can share the link to the webinar that we had earlier in August, maybe even in the chat feature. Maybe I'll ask Chris, who I think is on the line, to do that. And that webinar, we spoke about eligible expenses for the implementation funding, which included patient, family, and caregiver stipends, clinical and physician leadership, certainly, and project management as well. So I think that would, backbone is a broad term, Paula, but I think we'd have you pretty well covered on those aspects.
Good. Thanks for those. So I think that's been a couple of good. So thank you, Allison, and thank you, Lily, so much for coming and sharing, and I think also giving a voice to our work and letting people know that their contributions, we're a conduit, right? We're going to go out and we're going to try and listen to you in the OHTs across Ontario, and then in our view is that we aim to support you and aim to provide our support to the ministry as they help make decisions, and I think we're seeing that reflected. So we're just trying to be honest and transparent about this as possible. And so it's a value to us to be able to structure some of the feedback from all of the OHT participants to the ministry about areas where there are opportunities. So I think I'm just going to wrap up here with a couple of just additional resources. Keep the chats happening just so that everybody knows a few of these points. First off, key resources. the ministry has organizing central program of supports for resources and assistance to improve the readiness for Ontario health teams. And there are a couple of key places where you can get this. So first off, you can access the core at the Ministry of Health website. And some of the key resources there are the Digital Health Playbook, the links to Rapid Improvement Support and Exchange, and there's a whole program over at OHT Rise, and there are many, many resources available at that website. I can't imagine that anybody participating today has not already been over there, but go over often and early and often, because there's a great, they're doing a great job at really making resources available. And finally, through our own website, you'll be able to find you'll be able to monitor the progress of OHTs as they move forward through our evaluation work. And we also have some other resources that we've already made available. There are some practice guides, some advice on implementing integrated care, involving patients and caregivers, thinking about how to translate the key activities that have to change and manage with providers and managers, and finally a piece on collaborative governance. They're all available in one compendium, but also separate guides. We also had in February a logic model webinar, so you can look at our resource on that, see the webinar that we had, and we worked with a couple of our partner OHTs in showing how they were using logic models to really think through their processes and decide on what the right metrics are. We're going to be back with more work that'll take that to the next step of identification of metrics. We did a little bit of work there, but that's coming again. And as we bring webinars to the course, we're going to do this on the 4th Tuesday of every month from 12 to 1:30. So you can just mark that in your calendar from now, at least until March 2022. We might take a month off next summer, depending on how it's going. But our intentions are to be here every month with you and your colleagues implementing OHTs. A couple of things that will come up: generation of integration, thinking about the hard conversations that we learned from past efforts in Ontario. A focus on the measures for local evaluation. That's what I was alluding to with the logic models, of taking that to the next level of where your local measure is going to be. And groups will be identifying measures for their collaborative decision-making arrangements and agreements. And so how are you going to enact those locally, and how do you make those meaningful? I really recommend that you choose meaningful measures that allow you to track progress in your OHT for those. We'll be talking about population health management. We'll have a few events on this. And finally, we'll be bringing much of our developmental evaluation, both the plan. We'll have one note so you guys know a little bit more about what we're up to, and then also many results. And as they evolve, we'll be back every few months with updated results, similar to what we did today, but obviously the context and what we're sharing will vary. That's all I have to say today, and our team, and on behalf of our entire team, our speakers today, we are so pleased that you were able to join us. And please do, we will make these resources available on our website. We'll have a video recording of our conversation today. The slides will be available. We are making everything available as soon as possible. And we'll be back next month. So mark your calendars, and take care, everyone. Really appreciate your coming out.